Hello, my name is Erin Cox, physiotherapist, and today we're going to talk about the wrist. So we'll start with a little bit of wrist anatomy. So the wrist is going to consist of the inferior radio-ulnar joint, the radiocarpal and the ulno-meniscocarpal joints, the midcarpals between the proximal and distal rows, and then the intercarpal joints. First, we'll start with the inferior radio-ulnar joint. Now, don't forget, when you're evaluating the inferior radio-ulnar joint, you also want to look at the proximal radio-ulnar joint because they move together. Obviously, it's the same bones being connected at two ends. So the inferior radio-ulnar joint, you can see that the radius has a concave surface and the ulna a convex surface. Normally, it's the radius that's going to move around the ulna. So think about that when we do our mobilizations, that it will be a concave surface on a convex surface. In terms of ligaments, we have the palmar and dorsal radio-ulnar ligaments, and they blend into the TFCC to form the dorsal and palmar thickenings of the structure. And we also, of course, have the interosseous ligament. So we see here the palmar and dorsal ligaments, and then the TFCC would be between the distal ulna and the triquetrum and lunate. Now the capsule encloses the inferior radio-ulnar joint, the TFCC, and the carpals. So it's thickened anteriorly and posteriorly, but lax proximally, where it pouches into a recess between the radius and the ulna. The capsule, the inferior radial-ulnar joint, the radiocarpal joint, and the ulno-meniscal joints are all in the same capsule, provided that, well, they're all in the same capsule, but the synovium can be separate, provided that the TFCC is intact. If there's any kind of degeneration or proliferation of this TFCC, then it will communicate and the synovium will all be one. So the triangular fibrocartilaginous complex, or TFCC, this is a good image because we see the ulna here. This is the styloid of the ulna, and then the radius. And we can see that the TFCC extends from the just inside or just lateral to the ulnar styloid process toward the radius. And we can see how it separates the inferior radial-ulnar joints from the carpal bones here. And don't forget, when we talked about medial and lateral, in the anatomical position, which would be like this, oops, I'm too short, the radial side would be the thumb, which would also be the lateral side, and the ulnar side would be the medial side. And like I said, the TFCC is between the ulna and the lunate and the triquetrum. So the TFCC is composed of vestigial remains of the dorsal and palmar radio-ulnar ligaments, which would be here, the articular disc, which we're looking at, the ulnocarpal ligaments, and they have the ulno-lunate and ulno-triquetral depicted here, and you'll also see an ulno-capitate ligament as well. I have another image for that. The meniscus, which extends in from the ulnar collateral ligament. And the ulnar collateral ligament will be reinforced by the extensor carpi ulnaris sheath. So this is what I was saying about the ulnocarpal ligaments. You'll see in the literature that they're all grouped together, but it would be the ulno-lunate, the ulno-capitate, and the ulno-triquetrum. So ulno-lunate, ulno-triquetrum, and ulno-capitate. Strong attachments to the palmar and dorsal distal radio-ulnar ligaments. You can kind of see here. From a posterior view, this is just, again, you can see this is a dorsal radial-ulnar ligament and the other two ligaments we just talked about. And we can now here see that the extensor carpi ulnaris sheath will reinforce the ulnar collateral ligament. Here we see them connected. So the fibrocartilaginous disc, and this is what we see here, it's triangular and it binds the radius and ulna. It's thickest in its periphery, yeah, a little about 5 millimeters thick on the ulnar side, 2 millimeters thick on the radial side. And again, it extends from the ulnar styloid process to the ulnar side of the radius. And it helps in joint congruency. The meniscus are small projections into the joint from the deep fibers of the ulnar collateral ligament. And the function of the TFCC, it cushions the wrist joint. It disperses forces in weight bearing. It increases joint congruency with proximal carpal row. And it joins and stabilizes the distal radial ulnar joint. So this would be important. This could be an exam question. So it disperses the forces. So if it's intact, the TFCC, the radius will bear 60% and the ulna will bear 40% of the weight. So it's a little bit more equally distributed. But if the TFCC is not intact, then the radius bears a lot of weight. And this could mean that there could be early degeneration of the radius. Factors related to damaging the TFCC. So there's a certain progressive degeneration due to age. I'll show you the study in just a minute. Repetitive weight bearing, unfortunately, I think that could also be us as physiotherapists. Wrist trauma, usually in pronation and extension, and a positive ulnar variance. So ulnar variance, positive ulnar variance is if the ulna is too long, so you can see what happens here, or a negative ulnar variance, so the congruency is less. I had a positive ulnar variance, and I had pain since I was about 12 years old. I always had pain, often using a knife, trying to open doors or open jars, and it finally got so painful I ended up having surgery. And what they did is they had to cut off the end of the ulna bone. And even when I was drinking, I remember my friends were always like, "Put your elbow down," but because my ulna was too long, I did not have ulnar deviation. So if someone simply checked the radial and ulnar deviation, normally you should have more ulnar deviation than radial deviation. I was the opposite. I had limited ulnar deviation. So this is the study I was talking to you about. So there's decrease in cells, decrease in elastic fibers, mucoid degeneration, and fibrillation and ulceration. And the central parts are more cartilaginous and the peripheral parts are more ligamentous. And that's in a normal joint. And they did a study looking at fetuses all the way up to 94 years of age. And now you can see in this table that on imaging, so first and second decades of life, there's no real change and we see a normal appearance. But as we get into the third and fourth decades of life, we start to see less of a normal appearance. And then over the 50th decade, there's never a normal appearance. So there's some degeneration that just happens with age. And this can be symptomatic or not, because not everybody has pain in the distal radial ulnar joint or on the ulnar side. So another, the accuracy of diagnostic imaging, I also had an MRI with the coloring, and that's how we saw it. And the sensitivity is 74% for a complete tear. So if it's not complete tear, they'll see it. And specificity, 80% accurate. So the global predictive value is 79%. So it's not bad, but plus your clinical tests, and we'll go over that when we see each other in class. The clinical presentation of lesion of the TFCC, localized pain at the distal radial ulnar joint, usually in the medial ulnar side, pain with active pronation and supination activities, like I said, opening doors and jars, slight decrease in active range of motion, usually in pronation, ulnar deviation and extension, or there may be just hypermobility or hypermobility where the biomechanics are not followed. Clicking during movement, I definitely have that. Often when I'm working, I have to tell people that's not you who cracked, that was my wrist. Pain with compression of the ulnomeniscal joint and or with overpressure of end range pronation, ulnar deviation, and also shearing of the radius and ulna. So don't forget, if the TFCC is not intact, then it is less stable at the distal radial ulnar joint, or also in the ulnomeniscal carpal joint. Often we'll have that piano key, and you can do that, just that general shearing, click, okay. Pain with weight bearing and with resisted movements, we'll look again at some of these tests in class. So think about your TFCC tears. There is research, but think about activities that give you that pronation extension, like divers will often have this position. Gymnasts are weight bearing in extension, both in pronation or racket sports, so repetitive, trying to stabilize the wrist, boxing, any kind of repetitive extension or deviation. So fall on hand in extension, that's definitely where I really tore it the first time. And the other time was when I was getting out of bed and pushing myself up. And of course, fracture of the distal radius or ulna would cause a TFC tear. Thank you.